Good evening, welcome to One-on-One, a show in which things are looked at critically. We look at what's working and what's not working. So tonight we sit down with Eric Dziuban, who is the Country Director of the Center for Disease Control and Prevention here in Namibia. Good evening, sir. Welcome to One-on-One.
Thank you so much.
Maybe you could just clarify, what's the mandate of the CDC, particularly here in Namibia?
Sure thing. We've been here since 2003, and primarily we've been focused around the HIV epidemic in Namibia, just like a lot of your neighboring countries. So PEPFAR, many of your viewers may have heard of it, U.S. President's Emergency Plan for AIDS Relief. And this is a focused effort on controlling the HIV epidemic globally, and this has been the main driving force of CDC's presence in Namibia, our partnership with the Ministry of Health for the last going on 15 years now.
Okay. What would you say has worked and what hasn't worked so well?
Namibia has actually shown a tremendous amount of success in PEPFAR, and really in a lot of ways it's the leader in Africa. The targets set and the achievements met for getting people tested for HIV, on treatment, saving lives, have worked better in Namibia than just about anywhere else. So overall, Namibia can be really proud of how far they've come. There's still a ways to go. Not every target's been met. Namibia has ambitions to do even better, to make sure treatment reaches everyone who needs it, but they've come a long way. Some of the challenges have been reaching the hardest to reach populations. So for instance, for HIV testing, we've gotten a lot farther with women than with men, particularly young men. In general, young men are less likely to go in and get tested for HIV. And we know that they often don't access healthcare facilities broadly as much as women do of the same age. So we're trying to find ways to reach those men, encourage them that an HIV test is in their best interest.
How would you say, for instance, the classification of Namibia as an upper middle income country when it comes to resource mobilization that is then required to kind of bridge the existing gaps or the deficits? How has that affected the work that you've done with the Namibian government?
I think it could be challenging. Upper middle income, to some people on the outside, they might think, oh, Namibia doesn't need help, they don't need partnerships. They're ready to just work on their own and we should all walk away. U.S. government doesn't feel that way. CDC doesn't feel that way. We're still here. We provide a substantial amount of funding to partner with Namibia on the epidemic here. So that upper middle income status is not something that's going to affect how we drive our work decisions. We're sitting alongside Namibians and saying, what's still left to be done?
Okay. But there is a perception that exists that institutions like yours and other that come from protecting the interest of developed countries. Sometimes it's used as maybe you are deeming the ministry to be a partner, but you could actually be using that as a sphere of influence to kind of get your health agenda across.
Yeah, I don't think there's been much of a U.S. health agenda that's been pushed on Namibia. And our partners in the Ministry of Health, up to the minister, we've had really good relations in that way. Really, it's been to the benefit of Namibians. Now, as an American, I could say I'm happier that more people around the world are getting HIV treatment. I think it is better for America to have healthier global partners and friends around the world. But we're doing that through addressing the needs of Namibians.
But the people say that the health agenda is largely, if you're looking at the allocation of funding that, for instance, comes from PEPFAR, it goes largely more towards pharmaceuticals and the acquisition of ARVs, and other people are saying that you don't support, for instance, community initiatives. And if you look at the decline of civil society in a place like Namibia, that American companies are the ones selling the pharmaceuticals to these countries, and therefore you have a vested interest.
Yeah, actually in Namibia, that hasn't been the case at all. So of all countries that PEPFAR supports, Namibia is one that stands out the most for purchasing their own pharmaceuticals. So getting HIV medications, the daily medication that people living with HIV need to be healthy, to sustain their lives, TB medications, those are purchased by the government in Namibia, and it's actually not funded by the American government, by PEPFAR.
But what does PEPFAR then fund? Where does PEPFAR's money go if you look at allocation?
Yeah. Most of our money is going toward health services. In fact, almost all of it toward getting those services to people in need. So some of that goes directly to the Ministry of Health and our partnership there, and sometimes to outside organizations. So that might be international NGOs. It's oftentimes local NGOs run by Namibians with Namibian boards of directors. Sometimes it's civil society organizations. We have actually a lot of civil society partnerships that we are funding. That's a key component of this HIV response. So we do put our money there, and a lot of it's going toward, for instance, the salary of the person who's actually going into a community to find those most at risk for HIV, describe testing, and offer HIV testing to them. That's where our funding is going. Of course, medications are part of that and need to be purchased, but that's being done by the Ministry of Health.
Okay, but let's talk to a little about what civil society deems as a funding gap. How can they strengthen or respond better towards the gaps that still exist in ensuring the complete elimination of something like HIV?
Yeah, I think civil society has a lot of challenges because often these are smaller organizations. They don't have the reserves of capital to fall back on. They don't always have the broader networks of experts in grant procurement and these things. So it can be more challenging. And the U.S. Embassy is actually working with civil society organizations to try to help in those skills that are sometimes silent, right? We're not talking about their expertise in health or in specific communities. We know they have those. But we're actually trying to help civil society organizations have those skills in managing international grants so they can be competitive in receiving those funds, being accountable for those funds, and getting results.
Okay, so in strengthening community responses, how do we have the agency, for instance, in empowering it almost seems like largely African countries like Namibia depend largely from foreign funds. Namibia actually is an exemption to that case because we contribute 65%, but 35% is still largely outside of our own hands. So is that a model? Should a country's health agenda be a multi-sectoral, a multi-country, multilateral kind of approach? Is that what's showing to work most effectively?
I think that's what we're seeing right now. Namibia was in an HIV emergency. Nobody doubts that. The level of HIV had the 6th highest prevalence of HIV in the world. Over 10,000 people dying of HIV alone every year. For a country the size of Namibia, that's huge. And your viewers, many of them I'm sure remember a time that I'm told about when every weekend was full of funerals. And there were funerals during the week because there wasn't enough time in the weekends to have them all. That was a health emergency. And bringing in international friends, partners, international funding was appropriate for that. And now we're sitting and we're working together, and we are looking every year for more ways that this can become more Namibian-driven. They can be more about indigenous groups, local funding, and that is the goal that everybody has. At the same time, we don't want to just do that overnight and say, okay, today is the day Namibia does it, and we're not a necessary part of that.
So what's been the greatest achievements of CDC here so far?
There's something called 90-90-90. Some of your viewers may have heard of this, many probably not. These are international goals set that every country would have first had 90% of the people living with HIV know their status, know that they're HIV positive. Second is that of those people who know they have HIV, 90% of them being on treatment, the medication they take every day to stay healthy, stay alive. And the third is that of those on treatment, 90% are virally suppressed. That means that HIV is not circulating widely through their bodies. They still have HIV, but it's dampened to a level that it's not harming their health, and critically, they're not spreading it to their partners or the people around them.
Is that the ultimate vision, the 90?
90-90-90, yeah. It all gets us to that viral suppression. That prevents new transmissions, and it keeps people alive and healthy. And so the international community set those goals that by 2020, countries could reach that. And Namibia is closer than any of its neighboring countries at that. The numbers that came out at the end of 2017 were 86, 96, 91. So really the main gap still to get to those targets is, like I said, young men getting tested. Because for women, that HIV testing is already at 90%. But it's lower for men, and so that's why we're especially trying this year to reach young men, make sure they know getting a test for HIV is critical for their health and for their families.
Okay, let's keep it there for now. While we're speaking to the country director of the CDC. When we come back, obviously in honor of World AIDS Day, we'll be looking at what does the current status mean for those that are infected or affected. Stay with us.
All the benefits, no year limit. Now all Toyota service plans are #timeless.
The NBC management would like to inform all esteemed TV set owners that in an effort to reduce costs and conserve the environment, the TV license department will not send out invoices to all its clients this year. For more information or inquiries, clients can contact the TV license department directly at 061-291-3111 or 291-2100 during office hours or via email to tvlicense@nbc.na. NBC, it's ours.
Welcome back. We're speaking to Mr. Eric Dziuban, the Country Director of the Center for Disease Control and Prevention here in Namibia. I think maybe let's looking at from a strategic point of view. The government, with its partners like yourself, came up with the strategic framework for HIV and AIDS with various pillars and various key indicators. Maybe just tell us what was the intent or the objectives of that framework.
Yeah, that was led by the Ministry of Health. We were happy to be able to support them in that. I think what you see with this strategic framework, and anyone that's going to be successful, is prevention and treatment both have to be strongly represented. Mm-hmm. So prevention of new HIV infections, but then also treating people living with HIV, both for their own health, for them to be able to survive, to thrive, to have healthy, long lives, but then also that helps to prevent new infections, because when their virus is treated, they become essentially unable to pass HIV to another person if they're taking their medication properly and such. So a lot of people internationally say treatment is prevention. So the two come together, but both of those pillars have to be represented. And sometimes they need to reach unique populations.
Okay. But in terms of, you're referring earlier on to young men that are still more vulnerable. What are the key populations that seem to be most at risk?
Sure. So when we're talking about people living with HIV and not knowing their status, like we talked about, young men, but also men who have sex with men, transgender women, female sex workers. Those are populations where we know they're more likely to get infected with HIV because of behavioral risk, but also to not necessarily have good connections into the health community and the health services.
But that's interesting, because how do we prioritize something that intersects so much with social taboos? When you're talking about men having sex with men, when you're talking about other vulnerable communities, is there political buy-in to support those groups?
I think people would be surprised to the level that Namibia's government, along with the partners, is working to make sure health services get to those groups and to try to reduce the stigma and do it with really sensitive relationships in the community so these things don't happen overnight. But groups, partners, government workers who are specially trained to really make sure that they can sensitively reach out and let people know this is about their health. It's not about stigmatizing behaviors. It's about identifying who needs the services. Because we know it happens. People go to health centers and they might feel like they get discriminated against. And there's a lot of commitment to reducing that, because ultimately that hurts everybody.
Is there really commitment when you're seeing the Minister of Health saying, for instance, we want condoms in the prisons, and at the same time, other government officials are against that? So what are we saying? Are we trying to be Machiavellian about this, saying people that there's actually political buy-in when there is not? For instance, in the instance of the prisons, are prisoners' rights to their health not respected when they don't have access to things like condoms?
Yeah, I think there were advocates. I was in Amsterdam a few months ago now. There's a large HIV conference. The minister was there as well. We were announcing some of the results we talked about earlier of Namibia's successes. Mm-hmm. And he got up and publicly spoke about his interest in prisoners having access to condoms. And he was really recognized from leaders of that conference, from some of the advocates representing some of the key populations, that they were impressed that a minister of health of an African country would go out and say that publicly. So,
is that good enough? Is saying it good enough when people could actually be contracting the virus, not receiving the necessary help currently in prisons? Is that not just symbolic posturing?
Well, I think that having those conversations is an important first step, and it's Namibians who will decide how much is enough, what more do we need. We hear a lot of times from the communities saying they need new or better services, particularly their community. They say, it's great what's going on, but in this village it's too far away, and we see that people aren't on their medication like they're supposed to be. And so then we try to work with how to get better access there. I think it's the same with the prisons. It's the same with any population. I know that we get a lot of useful feedback from the community, and it drives things like the strategic plan.
But in principle, how does somebody, or an agency like the CDC that's attached to the U.S. Embassy, how can you use your political influence to engage, the powers that be, and ensuring that every Namibian accesses health?
Yeah, I think this is a large part of what we do, and what we enjoy doing while we're here is bringing in our resources and the values that we see that will help in this epidemic. We know from experience that you can't stigmatize HIV and expect to control your HIV epidemic. People go into the shadows. Again, your viewers will probably remember a time when, by and large, having HIV, it was a death sentence, but also it was almost a sure sign that you'd be stigmatized and possibly thrown out from your community. I've heard stories like that all the time. I'm a clinician, I'm a physician. I used to work in another country in Southern Africa providing HIV care and treatment, and I saw some terrible stories like that. People that have been thrown out of their families, children that have been abandoned because of their HIV status. You don't see that as much anymore. I'm not saying it doesn't still happen, but we've really come a long way in there. And I think that when I see Namibians step up and say, you told us we don't have to be ashamed of our HIV anymore, we could be the face of HIV in this country, and now here we are, I think that's a very positive sign.
But would you admit that some of the health interventions, whether they're at a global or local level, had an anti-HIV approach versus a pro-health approach? And so the kind of knock-on and domino effect of this is the stigmatization. You know, when you're saying on the one hand, if you're positive, your attitude must be positive towards dealing with this. If you're negative, remain negative. But rather than sending the same message, we send a divided message. And this could be largely be driven by agencies that are looking at the principle of HIV as an anti-approach versus then advocating for pro-health. Do you think there's that misunderstanding?
I think it could be hard because we absolutely want to prevent new HIV infections. And some people might take that to say, well, so HIV is bad, so people with HIV are bad. And that's not the message at all.
But can it be interpreted as that? Because there's difference between perception and truth here.
It could be interpreted that way.
And how do you deal with that risk or that harm that the opportunity, the cost of that?
I think, like we said, looking at prevention and looking at treatment, that they're both equally important. Like I said, treatment as prevention. We know that getting people on treatment helps prevent new infections, but that's not why we get people on treatment. The reason for someone living with HIV to get life-saving medication is not so they can protect someone else from getting HIV. That's a part of it, but we're talking about their health. We're talking about their well-being. The more that Namibians have seen the good effects of being on treatment, that HIV doesn't have to mean this death sentence, that it doesn't have to mean their life is cut short. It wasn't always that way. I remember, again, in another country, talking to school children, and they were taught in schools, and I think it was meant to be well-intended, but they were taught, oh, if you have HIV, you can live up to 30 years on treatment. And the teachers thought they were giving the right message, that that was positive. But let's say you're 15 years old, and you know you've had HIV since you were born. You do the math, you say, okay, I'm gonna die in the next 15 years. So why should I bother finishing school? Why should I work hard to get a job? Why should I fall in love? Why should I have a family? Because you think that you have a very narrow time to be an adult. And the reality is that's not true. It was actually false information. People can live much longer than that. They can have a full lifespan.
And that's precisely my question, because is the lens primarily on anti-HIV, or is it looking at the person's health? Because what's been shown also is that when we have a holistic health approach towards HIV and we don't isolate it from our general health, that actually the benefits get compounded.
I absolutely think so, and I'm glad you brought that up, because we talk about HIV care and treatment. It's a phrase we throw out a lot, and almost to where you forget what it means. The treatment part is usually where we're talking about the specific antiretroviral medications. So what's care? And a lot of times care is looking at all the rest of the parts of the person's health. TB screening and TB prevention. If somebody gets on HIV treatment and then they die of their TB, have we really done anything useful? Another one that's very recently been introduced in Namibia is cervical cancer screening. And now saying that all women living with HIV should be screened for cervical cancer, because we know that women with HIV are 5 times more likely to have a deadly cervical cancer if they get infected with the human papillomavirus. So these are things looking outside of that immediate emergency need to get on the HIV medication, to say what else does this person need to have a full and holistic health approach.
We've also seen, and a lot of people are arguing, for instance, when it comes to HIV rapid testing, the kind of additional support services that are needed when people get tested, and therefore you might see a lot more women going to get tested because they have naturally more support structures around them, and they're allowed to be more vulnerable in this context, but you don't see that kind of phenomena when it comes to the man. How strong of that is that an emphasis in your intervention, not just symbolically, but how do you meaningfully carry that out? And is there enough resources to back that kind of additional psychosocial support?
Yeah, I can't say whether women get more social support for things like HIV tests. I'm sure it depends on their individual context. How supported are they in their homes, in their communities? But we do see, in general, women are more likely to access those services. For men, they might not feel as comfortable. Now, I don't want to overemphasize that point, because actually Namibia is doing quite well in testing men compared to neighboring countries. It's just that we know it could be better, because we've seen that the women have already
Well, my question was around
90%.
additional services, the counseling, the psychosocial help. How well do we do just beyond giving a person the medicine? Because we know that the other gap is also required in terms of the community's role, how they are then accepted in their families. How do we do in terms of sensitization, providing the necessary materials, advocacy campaigns for that type of psychosocial support?
Yeah, that's a huge component of it, and the HIV education. So we want communities to understand HIV well, and there's good evidence that they do understand a lot more about HIV than previously. But that individual getting tested, they need to understand what that result means. If you just get an HIV test and you're told you're positive and that's all you hear, a lot of negative, a lot of false information could fill that gap. We know that there's misinformation out there, and it's in the communities, it's in different publications. We don't want that to be what people take with them. They need to hear the correct messages about what that diagnosis means for them, for their partners, and what the future holds. Okay, what's next? What is it gonna mean then if I get on treatment? That has to be a part of it. If we just test somebody and then out of fear, they walk away from the system and they don't get on treatment, again, we didn't really accomplish much for that person. We didn't do them much good if we don't link them to an effective whole health approach.
Okay, let's keep it there for now. Well, maybe when we come back, we look at the future of, obviously, this intervention and how we're going to deal with organizing ourselves to respond to the epidemic of HIV. This is One-on-One. Stay with us.
My name is Dola.
Nomad.
Ruby.
Gerson Toesep.
Treza.
Yeah, man, this is Bantusan Favorite Reds.
Patana Peixe Dongoro.
Ahue.
Blomiki Shaningwa.
Miss Yvonne.
Bakos Maruhoveka.
Hans.
My name is Ted Scott, and I give myself a Nomgumbe.
Welcome back. This is One-on-One. We're speaking to Mr. Eric Dziuban, who's the Country Director of CDC. I think what we need to then kind of focus on now is the future of how we're going to organize ourselves in responding to the epidemic of HIV. But one of the key things is decision-making and what influences decision-making, whether that's at a global level, regional levels, at local levels. The CDC prides itself and says that a lot of your decision-making is based on science-based, data-driven. But we know things like publication bias exists. There's also been a lot of criticism in epidemiology around what is statistically significant versus what's significant in life. So given these kind of challenges in terms of how we're going to make decisions, what's the anchor for the CDC in decision-making when it comes to health?
We do absolutely want it to be data-driven, you're right. CDC, through PEPFAR, U.S. government, partnering with the Ministry of Health, we have a lot of data points. We really want to know what's happening, not just region by region, district by district, but right down to the site level. Where are we finding that people are HIV infected? Where do we have gaps between people we know need the services or not? So all that data is there, and we're using it to drive the program. So for instance, where are the places where we know that there's the most new infections? We talked about men who have HIV not being tested, but actually for new infections, what Namibians are getting infected this year, it's actually young women, far more likely than men their own age to be infected. So we're using data and then also new innovations. So we're rolling out HIV testing that not just tells you if you're HIV infected or not, but actually if you have a more recent infection. And that's going to help us identify then geographically where the recent infections are occurring. That's going to let the Ministry of Health focus their efforts on HIV prevention where they know the most new infections are happening. And we support that. We really, some results get published, but we're not driven by our motivation to publish. PEPFAR doesn't have indicators. For instance, our performance is not based on publishing or some of these things you mentioned. It's really about program results. The targets we set aren't number of publications, it's number of people on treatment, number of young girls getting prevention services, number of HIV tests performed.
Yeah, but why I'm asking this question is because trends change. Like you're saying, the trends 3 years ago might not be the same trends, but how are the institutional arrangements set to respond to those ever-changing trends? Because sometimes you might have the data, but the system can't respond.
Yeah. And right now what we're seeing is that even getting the data is something that has to be incorporated into the system. So we had this large study that I mentioned that took place last year, but we can't stand on that study forever. We're going to want to know in a few years, how is it the same as it was? How has it changed? How do we need to alter our response?
But my point is sometimes we know things. So even in knowledge acquisition, you might have an understanding of something, but the application and the response in terms of institutional arrangements, in terms of issues of capacity, in terms of resource mobilization, how do you deal with the pre-enabling factors that's going to allow us to then make use of the data once we have it?
I think the planning process has to be really robust. So we have the data, and then we need to say, what are we going to do in the next year with that data? We have strategic plans, and that's great, but we don't do a strategic plan for 5 years and then just stick with it. Because like you said, the data will change, the needs will change. So
and are the institutions capable to absorb the change is more my question.
Well, you know, so far they really have. Namibia has pivoted where they needed to. A few years ago, it was understood that the north was really struggling, particularly the Kavangos, Zambezi region. The treatment was not getting up there the way it was here or maybe in the larger towns like Oshikari. And so there was a huge pivot, and the system responded, and it changed its approach. Another example is for HIV testing. We used to almost exclusively, or in large part, do home-based testing, door-to-door, literally going door-to-door and offering HIV testing. New data came in to say that's not necessarily the most effective. You do a lot of tests to find out a smaller number of people with HIV. But if you focus on index partner testing, someone who has HIV, and then sensitively talking with them about the people around them who might be at risk, their partners, the children or the women with HIV, finding those people, offering them testing, you get a lot better results. You reach more people who need that help. So these are a couple of examples where Namibia really has pivoted to change their program in response to the data.
Okay. Obviously, as we're winding down the program, you as the country director, why are you qualified for this job?
Well, the HIV response has really been a huge part of my career so far. Like I said, I did it at a very different level where I was actually in a clinic, seeing patients, sometimes dozens, sometimes 200 patients a day living with HIV. Children, pregnant women, adult caregivers, everybody. Seeing it at that level affects the way I operate in this capacity. I do feel like that's a strength that can be added when people in the HIV response understand what it's like, not just at the policy-making decision, not just when we're talking about research or programs or funding, but what is it really like for the people who are most affected by this program?
Okay.
And when you've had that experience, when you've walked hand in hand, when you've been to the funerals, I think it gives you a perspective that'll really help strengthen what's going on here.
As we commemorate World AIDS Day, what's your message to those that are infected and those that are affected?
That there's a lot of hope, that there's a lot more hope than there ever has been before in Namibia for people living with HIV. The treatment is getting so much better all the time. So for most people starting HIV treatment in Namibia, you'll be able to be on one pill once a day. And the pills have a lot less side effects than they used to. Getting tested, getting on treatment, it's so good for your health. But then that thing I mentioned before, it could be a real game changer for people, knowing that if your treatment is effective, if you're taking it every day, if it's doing what it's supposed to, you are no longer having a risk of infecting the people around you, even your sexual partners. What I've been told is that provides such a relief. It takes away some of that internal pressure, that fear that you have that you might bring harm to someone around you, that's incredibly relieving, and it just really lifts your spirits. So I would encourage people out there who might be HIV infected, find out your status. If you already know you're living with HIV, but you've been afraid to get on treatment, think about what that relief could mean, knowing not just that you're helping yourself, that risk goes away. That can really change your life.
Okay, thank you very much, Mr. Eric Dziuban, and all the best with your work. Thank you. Well, there you have it. In commemoration of World AIDS Day, we have a personal responsibility to ensuring our health, not just individually, but as a nation. That's all the time we had from me, Patrick Sam. It's a good night.